Biology or chemistry or something.
Hello, Prof. I guess we can start now.
What is diffusion?
Okay. Should be in a minute. All right. Good evening, everyone, and welcome to today's lecture or discussion. Yesterday, I talked about deficiency anemias. And during the follow-up discussions, I mentioned that I wasn't talking about anemia in general, but a type or a classified type of anemia, and that there were other forms of anemia. And so today I want to discuss hemolytic anemia, which is another form of anemia. And they all have different underlying causes. Okay, for these anemias. So that is what we will be discussing. Just for a moment, let me look for something. I'll just be a minute. Okay, so where are we? Okay, so I'll just check on something. So we are going to discuss hemolytic anemia. And so it's described as a form of anemia as a result of hemolysis. And hemolysis will be expanded to mean breakdown of red blood cells. And usually the breakdown of red blood cells is classified as abnormal. Abnormal because the cells don't live up to the number of days that they are supposed to live up, like the 120 days, and they break down early. And so they are said to have hemolyzed. And this hemolysis or breakdown occurs in the blood vessel and also away from the blood vessel. So the one that occurs in the blood vessel, we say intravascular hemolysis. And then the ones that occur outside the blood vessel, as well in the human body, are termed as extravascular hemolysis. And for each of them, there are different components that can be detected in the blood to indicate whether the hemolysis was intravascular or extravascular. For example, if the hemolysis is intravascular, then you are going to see hemoglobin blood. If it's extravascular, then the breakdown is controlled in the spleen, for example. So the red cells are picked up by macrophages, so you don't see hemoglobin in blood. If it's intravascular, you're going to see LDH level goes up. If it's extravascular, you don't see that. If it's intravascular, you're going to see low level of haptoglobin. If it's extravascular, you don't see that. So depending on what you see, you can even determine whether the hemolysis or the hemolytic anemia is intravascular hemolytic anemia or extravascular hemolytic anemia based on the components that can be measured from blood. This hemolytic anemia has numerous possible causes, and these range from harmless to life-threatening. So therefore, the anemia that can occur could be mild, could be moderate, or could be severe. If it's mild, it's harmless. Moderate can be harmless or less, or more than harmless, and life-threatening is the severe type. And hemolytic anemias are about 5% of all anemias. Okay. These hemolysis can be as a result of a defect within the red blood cells itself, or an abnormality in the circulating environment. So the red blood cell itself can have certain abnormalities that can cause them to hemolyze abnormally. Then in some cases, the red blood cells are fine. They don't have a problem, but then they hemolyze abnormally because the environment is causing that to happen. We'll look at them in detail as we go along. So abnormal cells are prematurely lost from circulation because one, they are more readily phagocytosed in the spleen by macrophages. So this is extravascular hemolysis. And damaged and abnormal cells may break down more readily in bloodstream. This is intravascular hemolysis. I did mention earlier that hemolysis could be intravascular or extravascular. Either way, it is loss of blood. And because the red blood cells are being lost far more than we are producing them, then anemia is going to occur. So production cannot match destruction, leading to anemia. Okay. So classification, generally classified into either or whether the condition was inherited or was acquired. So we say inherited or acquired classification. Or classification of hemolysis, hemolytic anemia into inherited or acquired. And we're going to look at what that means. So if you have acquired something, that is, you were born with certain constituents or constitution of genetics, or there is something that you were born with, simply put, there is something that you were born with that may be causing your red cells to break down, then that type of hemolytic anemia is inherited. However, if you didn't inherit anything, but due to exposure to certain environmental factors, like even infection, that is what is causing your cells to be hemolyzed, then that will be part hemolytic anemia. Okay, you can also classify the anemia according to the means of hemolysis, either intrinsic, and if you have mentioned intrinsic, then you are going to have extrinsic. Okay, so the intrinsic, in cases where the cause is related to the red blood itself, such as problem with the red blood cell proteins or oxidative stress handling by the red blood cell. The red blood cell cannot handle oxidative stress due to loss of certain components or certain proteins within the cell, then that's the cause of the hemolysis is within the red cell and is called intrinsic. Okay. Then extrinsic, in cases where factors external to the red blood cell that is causing the destruction. These include immune attacks and microvascular angiopathies where red cells are mechanically damaged in circulation, and it can be intravascular or extravascular. This, I will go back here, back here. If you look at this one, we say the defect within the red cell or an abnormality in the circulation. So this one is looking at intrinsic factor, and that is looking at extrinsic factor. So the causes of the hemolysis, when we say it can be hereditary or acquired. Hereditary, mainly intrinsic causes. We can look at membrane defects. So this is intrinsic, right? The problem is within the red cell. So this type of hemolytic anemia is because there's a defect in the red cell membrane, okay? And the red cell turn out to become a spherocyte or an elliptocyte. And when red cells are spherocytes or elliptocytes, the shape is different. They're elliptical or spherical. And such red cells, when they make their way into the spleen, they will be quarantined. That means they will be removed. So there will be a lot of extravascular hemolysis taking place as far as those red cells are concerned. And that is because the membrane cytoskeleton has some defect. The ankrins that hook the membrane onto the cytoskeleton may not be down there properly. So the cell membrane, instead of forming the normal shape, becomes spherical, and the membrane defect leading to the spherocytosis then causes the cells to be hemolyzed. Okay. Then the next one under the hereditary inherited hemolytic anemia is defects in hemoglobin. This time it is not affecting the membrane, but it is affecting the hemoglobin in the red blood cell. So for example, if there is thalassemia where the globin chains have defects, so instead of 2 alpha, 2 beta, you have 3 alpha, 1 beta, or 4 alpha, no beta in terms of thalassemia, and sickle cell where you have hemoglobin A, S, hemoglobin, sickle cell is not AS, right? AS is what? Is a trait. And then the sickle cell disease itself, you have the SS or SC. This is a defect in hemoglobin, and because of the defect in the hemoglobin, they tend to form the sickling shape, and the sickled cells, when they get to the spleen, will be removed. There again, hemolysis has taken place, or the cells have been broken down earlier than expected. Then we have congenital dyserythropoietic anemia, where the formation and production of the red cells are defective, also leading to increased destruction. So all these conditions are hemoglobin defects, and the hemoglobin defects results in loss of red blood cells, or hemoglobin defects leading to breakdown of red blood cells in increasing amounts. We call the hemolysis. Any anemia as a result of defects in hemoglobin synthesis is therefore going to come under this hemolytic type of anemia. Okay. And the third one, hereditary hemolytic anemia, is enzyme defects, enzymopathy. And the first one is glucose phosphate dehydrogenase deficiency. You remember this was also mentioned as a deficiency anemia. Okay, so it is a hemolytic anemia as well as a deficiency anemia, because the enzyme is deficient. You need the glucose phosphate dehydrogenase to withstand stress. And so when they are deficient, the red cells cannot withstand any stressful condition and they will hemolyze. So people with that condition tend to have chronic anemia. Then we have pyruvate kinase deficiency. Pyruvate kinase breaks down ATP, I believe, releasing energy for the cells to survive. So when we don't have them, RBCs become hydrated and abnormal in shape, and so hemolyzes earlier than expected. So these two enzyme deficiencies can lead to hemolysis of the red blood cell. So under inherited, we have looked at defect in the membrane, we have looked at defect in hemoglobin, defects in enzymes, and all these are at the same time intrinsic because they are conditions that are within the red cell causing them to be hemolyzed. Okay? Okay. Richard, Koku,
Cut it out.
yes.
Yeah, mine has to do with like this is PD being under the enzyme deficiency and not
Yes.
under the membrane defect. I know that this is PD is a membrane. When you know this is PD, the membrane integrity of the cell is compromised. So why are we not adding that on to the membrane too? Against the enzyme.
Okay. For example, if you don't have the GCSPD is not a membrane molecule. It is an enzyme. Okay. Because you don't have that enzyme, the red cell cannot withstand the stress, and so it breaks down. How does the red cell break down? It breaks down when the membrane breaks up, but that is not a membrane defect. It is the defect only is as a result of the lack of enzyme. For example, let me get something in real life. If you have I use immunity, so I'm trying to get something in terms of security. Say you are in your room, right? And then you didn't lock the door and the thief came in and stole something. Can you blame the problem of the stealing on the door or on the person who didn't lock it?
The person didn't lock it.
Okay, but the thief didn't pass through the person, they passed through the door, isn't it?
Yeah.
Yeah, so even though they use the door to come in, the problem is not with the door, but it's with the person who didn't lock it. So the GCSPD as an enzyme, if it is there, will cause the red cell to withstand stress. But when it is not there, the red cell cannot stand stress, and therefore the membrane breaks down. And so as long as it's not a membrane component, it's not one of the proteins that forms the membrane, their defect cannot be attributed, and you can't put them under the membrane defect because it is not a membrane protein, but rather an enzyme that resides within the membrane area or within the cell. And therefore, if they are not there, the cell breaks down. But so because the cell breaks down through the membrane, that is why in some cases, it is mentioned like that, but technically, it cannot be placed under membrane defect because it's not a membrane component. It's not, membrane defect is to do with the structural defect, the proteins that form the membrane. So if those proteins are not there, then the membrane breaks down. That is why those are the ones attributed under membrane, but not enzymes that are, in fact, if you go back to here, sickle cell, okay, the membrane breaks down as well, isn't it? Because when the hemoglobin forms the fluid titus, they will pierce the membrane and the membrane will break down. You can put that under membrane. Who is making noise? You need to mute yourself. Who is it? Abraham. One thing. Okay, let me try and mute him. I'm going to mute all So when you have to ask a question, you have to unmute yourself. Okay. So yeah, Richard, that is the case. All right.
Yeah, thank you. I'm listening to you, please.
Okay.
You talked about splenic sequestration, that
The spleen.
abnormal rest
Yes.
are quarantined.
Yes.
I want to know, and you said that in intravascular hemolysis,
Yes.
parameters like bilirubin will increase and LDH will increase,
Mm-hmm.
and the haptoglobin will also increase.
Yes.
In this case, how do we, in the laboratory, how do we measure for extravascular? Because if those parameters are not increasing, but rather it increases in intravascular, how do I know, differentiate that in the lab?
Yeah. So for example, you have an anemia and you suspect hemolytic anemia, and you want to know whether the anemia is intravascular or extravascular. You measure those parameters. You measure LDH, you measure hemoglobin in plasma, you measure haptoglobin. If LDH is absent, plasma hemoglobin is absent, is normal or negative, LDH is low or normal, and there is normal haptoglobin, then that is an indication that if at all the hemoglobin is hemolytic, then it is extravascular. Okay, so you wouldn't be able to measure parameters that point to the extravascular except what are available to you. What is available to you is what you can measure from the blood. So now you do those ones. Then again, so how do you know it is extravascular? And how do you know it is intravascular? So if I want to know whether it's intravascular, then I expect to see high LDH. I expect to see high hemoglobin in blood, hemoglobinemia. I expect to see low haptoglobin. Why low haptoglobin? Haptoglobin binds hemoglobin, right? So if there is release of hemoglobin into blood, they are going to be complexed with the haptoglobin. So the level of haptoglobin will reduce. And this is what I can use as an argument. So you can even have high LDH, normal plasma hemoglobin, but decreased haptoglobin. And that can still be an indicative of intravascular. Without them, then the condition is extravascular. So it doesn't matter that you don't need to measure anything that is direct with intravascular so that you go and cut off the spleen and examine it. You don't need that because what you don't see can tell you that it is the other one. All right. So it's direct. If I hear you talking and you are not standing where I am, then you are on the other side of the wall. So I don't need to come there and find you before I can say that you are on the other side of the wall. So in measurement of parameters, you don't really need to measure a thing directly, but we know that you can measure things from the blood. So if it's in the blood, what does it mean? If it's not in the blood, it means something else. So then you take the alternative. I don't know if it makes sense to you. Yes.
It makes sense. But out of curiosity, I want to ask, when the spleen, quarantines those abnormal RBCs,
Yes.
and it breaks them down.
Yes.
Where does the component, the globulin and what happens to the globulin and the heme
Yes,
component?
the catabolism takes place in the macrophages. The spleen, when we say spleen keeps them and breaks them down, they are picked up by macrophages in the spleen. And so the process of breakdown happens in the spleen where the iron is stored in the macrophages. So you know that we have hemosiderosis in macrophages, right? And we have been mentioning that macrophages contain iron. They contain iron because the iron is, all the breakdown happens within the macrophages, and the ones that they have to release as debris, they release into the blood system to be taken care of in the kidneys. So there's a controlled breakdown. It's the macrophages that phagocytose them. You are familiar with the process of phagocytosis, right?
Yes.
Yes, so that is what happens. They don't just break like it happens in the blood vessel. They in the tissues, they are taken out by other cells. So it's a controlled process. That is what happens. Okay. All right. All right. So moving on, we go to where were we? Acquired, which is the extrinsic causes. And acquired hemolytic anemia may be caused by immune-mediated causes. Okay, so there can be toxic chemicals, there can be drugs, physical damage, and infections. Immune-mediated causes include factors such as mycoplasma pneumonia infection and cold agglutinin disease, which is a production of certain antibodies that can bind to the red cells and cause them to be hemolyzed. Then we have permanent factors as in autoimmune diseases like autoimmune hemolytic anemia and in systemic lupus erythematosus. So in autoimmune hemolytic anemia, for example, we produce autoantibodies that are picked up on red blood cells. And once they are picked up on the red blood cells, due to complement activation, the red blood cells are hemolyzed. But they are hemolyzed because antibodies were picked on them. That is how they got hemolyzed. Okay. Right. So acquired hemolytic anemia can also be due to burns. Okay. And as a result of certain infections. So when you are burned, you get burns even through normal steam. It can also cause the red cells to be broken down. Then we have lead poisoning. Lead poisoning can also cause red cell to be more fragile and they are hemolyzed. This is not immune causes. Whenever we mention immune, we are looking at antibody antigen effect. But in this case, the lead causes the cells to be more fragile and then they are hemolyzed. So lead poisoning. Then we have something called runner's foot or foot strike hemolysis. So if somebody runs a marathon, they can become anemic, perhaps temporary, but they say it will occur as they run and their feet is hitting the ground. They are causing mechanical damage to red cells from under the feet. So owing to the destruction of red cells in the feet, at the foot impact with the ground, they can suffer from hemolytic anemia. Then we have low-grade hemolytic anemia. So occurs in 70% of prosthetic heart valve recipients. I think this one. Hey, can you mute? Right. I may have mentioned it. Prosthetic heart valves when there are metal clips put in the heart valve, and what was I talking about? Organ transplantation. Okay, where they are now practicing heart valve. They are using heart valve from pigs to place in the human heart valve so that they will avoid the breakdown of red blood cells. But when you put the prosthetics in the heart and the red blood cells pass by them, they get scratched and broken. And so the damaged and scratched red cells, when they get into the spleen, they are removed as well. And so people with prosthetic heart valve may end up with hemolytic anemia. Okay, it says so low-grade hemolytic anemia occurs in 70% of prosthetic heart valve recipients, and severe occurs in about 3% of them. So it's still an issue to be grappled with. And in place of these prosthetic heart valves, they are working on using the heart valves from pigs, which is under the organ transplant as a xenotransplant transplantation. So transplanting an organ from one species to another, which is an animal species to human species. Okay, so because of this 3%. Okay, still on the acquired, we have paroxysmal nocturnal hemoglobinuria as well. So this one is referred to as McPhaver-Michaelis syndrome. The red, acquired, potentially life-threatening disease of the, so this should have been part of the acquired, isn't it? In the, other side, where was that? One moment. Right. Okay. I was talking about heredity. Right. Yeah. So potential life-threatening disease of the blood is characterized by complement-induced intravascular hemolytic anemia. In fact, I have not been discussing the process of the hemolysis. That is a different matter. Mostly, you learn that in immunology. So that is not what we are doing. And that is why when I talked about the quarantine in the spleen, I just mentioned they are removed and didn't go into the steps by which they are removed. Okay, so here also the same thing, but complement-mediated lysis is the main reason why you have peripheral breakdown of red blood cells. All right, now to the types. So the type autoimmune hemolytic anemia occurs. In this case, we bring in the immune part. So it's reflecting or because of antibodies that have been produced. And these antibodies are directed against the person's own red cells. So the auto part is there. They are directed against the person's own red cells, and they cause the red cells to lyse, leading to insufficient plasma concentration of red cell. Here, the lifetime of the red cell is reduced from the normal 100 to 120 days to just a few days in more serious cases. And AIHA can be due to warm or cold antibody types, and rarely the mixed type. Relatively rare condition affecting 1 to 3 people per 100,000 per year, right? So whether the issue is the type of antibody that reacts at 37 or at 4 degrees, you will still be hemolyzing the red cells. And how is this hemolysis come about? One, mainly complement-mediated lysis. Within the peripheral blood, there are very, very few macrophages, if any at all. So phagocytosis don't usually occur in blood circulation, okay? And so they have to go into the tissues for that to happen. Then also antibody-coated red cell, for those ones, when they also go into the spleen, macrophages will pick them up because you have antibody-mediated phagocytosis because they are covered by antibodies. Phagocytosis is easier, and the macrophages pick them up easily. So when you want to talk about the type, even though we were using the GCSPD as the, what do you call it, a course, based on the course, you also have a type like that. So you have GCSPD deficiency hemolytic anemia, right? As a type of it. And as I mentioned, it's common, the GCSPD deficiency is the most common disease producing enzymopathy in humans. And this is inherited as an X-linked disorder. I know you know these things. And affects 400 million people worldwide. You also do know that it is said to be one of the genes that confers protection against malaria. And that is why they are found highly, or they are in high frequency in malaria endemic areas. However, this day and age, people with GCSPD will still suffer from malaria anyway, as you do know. So the disease is highly polymorphic with more than 300 reported variants seen. And so it has variations. And because of the polymorphism, it affects quite a number of people. Said found in malarious environments such as in our area here. So the deficiency being the cause, it can also be a type of hemolytic anemia, as well as we mentioned, type of deficiency anemia as well. So acute hemolysis from GCSPD deficiency is linked to production of Heinz bodies. Here you probably don't see it quite clearly, but Heinz bodies are composed of denatured hemoglobin, okay, in the red cell. So when you find Heinz bodies, it's likely that, and if it's linked to anemia, then it's likely the anemia is due to GCSPD deficiency. Okay. Hereditary spherocytosis hemolytic anemia, another type. The spleen sinusoids are packed with RBCs. The osmotic fragility of spherocytes is increased. Majority clinical features are hemolytic anemia, splenomegaly, the spleen is enlarged, and jaundice. Okay, because the red cells are spherocytes and fragile, you can have both intravascular and extravascular hemolysis. And if the intravascular is high, the one may end up with jaundice because there will be high production of bilirubin that the liver may struggle to conjugate. So you may see more of indirect bilirubin being high, and therefore you diagnose them as jaundice. Okay, so we have hereditary spherocytosis hemolytic anemia. Then the thalassemia comes in. This is another type. So hemolytic anemia due to thalassemia, right? And we know that normal hemoglobin A, consists of alpha globin and beta globin. And normal structure has 2 alpha and 2 beta. Okay, but in some cases, the body doesn't produce enough of either of these 2 proteins. So the red blood cells do not form properly and they cannot carry sufficient oxygen. So you have 3 alpha, 1 beta, 4 alpha, no beta. And then similarly for beta, 3 beta, 1 alpha, or 4 beta, no alpha. And these are the abnormalities that can cause the red cells to hemolyze. because the hemoglobin, of course, is abnormal. So they cause hemolysis. So the result is anemia that begins in early childhood and lasts throughout life. Okay, so thalassemia patients normally undergo chronic transfusion, if I could call it that way. They are put on constant blood transfusion, and every other month or so, they will show up in the hospital to have their blood to have them transfused with blood, just to make up for the hemolysis that is taking place. Richard, your hand is still up. Is it the old one, or you want to ask a question again?
So it's the old one, please.
Okay, all right. Okay, so symptoms of hemolytic anemia are similar to other forms of anemia. So you still have the fatigue and shortness of breath. But in addition, the breakdown of red cell leads to jaundice and increase the risk of particular long-term complications such as gallstones and pulmonary hypertension. Okay, that is in addition to the normal symptoms of the anemia that you see. Diagnosis. The signs of hemolytic anemia include increased LDH. It says that LDH is sensitive but not specific. So be looking at this. I'm going to ask you some questions there when we go through them and have some discussion. Increase indirect bilirubin, sensitive but not specific. Increased reticulocyte count, specific but not sensitive. Decreased haptoglobin, specific but not sensitive. Urine hemocytrin, specific but not sensitive. So when you say, for example, increased LDH is sensitive but not specific, what does it mean?
No, no.
Yes.
But, LDH is not only found in IBC, so we have other types. So it's not specific to red blood cell, but it's a sensitive something. But it's not specific because it's not only found in IBC.
Okay, but in terms of sensitivity, means that it can be used to directly indicate hemolysis, right? But may not be may not be because of only hemolytic anemia that you can see high LDH. Is that what you mean?
Yes, sir. Yes.
Yeah, that's correct. So even though it's sensitive, it can happen. Other conditions can also have increased LDH, and so when you see increased LDH, it's not exclusive to uh, hemolytic anemia. However, if there is anemia, another parameter supports hemolytic anemia, and you also see increased LDH, then it will lend a hand to the arrival of the conclusion that you have hemolytic anemia. Increase in direct bilirubin, similar to LDH, may be as a result of other conditions, but can also be seen to have caused the condition. Increased reticulocyte count. That is specific, but may not always be seen. So may not be not sensitive, right? So in this case, because of the hemolysis, the red cells are dying far earlier than they are supposed to. It's not because their number is reduced and things like that. So the bone marrow being active will try to compensate, and it's not getting mature cells, so it will ship some immature cells out to come and compensate. Then we have decreased haptoglobin, which is also specific, but may not happen in all cases. And urine hemosiderin, the same thing. Okay. All right, so this is some of the picture that you will see. You will see the breakdown red cell, for example. This one here, part of it is chopped off, that one here, this one here, they are hemolyzing, parts are broken off. And then one or two stoma cells. You see these slits. You can see them in there as well. Okay. All right, treatment. Treatment depends on the cause and the nature of the breakdown. So when you find the cause and the nature of the breakdown, then you can use it to treat the condition. Right. Excellent. Any question for hemolytic anemia? Even though sickle cell is also can cause it. If you have any question there before I do the sickle cell part for this lecture, and then we go into some question time, then we call it a day. So anything for me to answer? Yeah.
Yeah. Please, I would like to know, how is the hemoglobin measured in the lab?
How is it measured?
Yes, please.
Yeah, haptoglobin can be measured. There's a method for it, but I can't have it off the top of my head. Yes, but there's a method for it. Yeah.
Okay. Okay.
So it will be one of the tests that we say special test, because it's not done often. Okay. Right.
Look.
Doc,
Yeah.
please, so it's the hemolytic anemia. Are we, before we diagnose hemolytic anemia, are we supposed to also do the blood film comment in relation to other tests, which is the LDL and the bilirubin?
Yeah, we doing the film comment like the picture that you saw will help. Okay. So when you have any, in fact, for all this, once there's anemia, it has to go for blood film. Once you see, so most laboratories have a protocol that says that once the hemoglobin is below 8 or under, you must do a film. It's mandatory. Some places that I have worked in have that as part of the SOP. So nobody even asks you, meaning that they want to do blood film, talking and checking. All right. They want to do blood film and at the same time to address any anemia that will be seen. I worked in some lab that have medical officers attached, and whenever you get a hemoglobin less than 8 or less, you have to do a film as mandated by the SOP of the laboratory, and you send the film for them to study, and of course the clinician will have a look at it. So in fact, any lab that sees blood that indicates anemia, you have to do a film and look at the picture. Otherwise, you may get the diagnosis wrong. But you have to know that unless specifically asked, we are not actually requested to diagnose the anemia. Normally, it goes beyond what we do in the lab. You need to know these things so that you can have a picture of it. So by sending your results, you have a certain picture in your mind. Just so, for example, HB is low, LDH is low, plasma hemoglobin is high, haptoglobin is low. What story does it tell? And then you just send it because you don't understand. But if you understand the fact that this is not giving me a good picture, you do a blood film and you don't see, or you see these echinocytes or broken down red cells, then you have to probably go and repeat some of the other tests to be sure if you are getting the whole thing right. But eventually, it will be the physician who will do the final diagnosis by putting all the results together. Don't forget that sometimes FBC alone cannot diagnose the type of anemia. They will have had to add the results from chemistry where they will go and do the ion studies, do the ferritin, sometimes even with imaging and stuff, all combined to diagnose, and the history that they will not normally supply you. And they are the ones who speak with the patient and ask them their eating habits and whether they are taking enough iron and stuff like that. You don't normally get all these things. So you are not necessarily supposed to arrive at a final conclusion as to diagnose the type of anemia, but you should have an idea of where this resource is heading towards. When you have those at the back of your mind, the results you will release will go and support what others have brought in, and it will tell a story. That is what we need to know. Like I said, in your laboratory, you have to have a protocol that says that any hemoglobin below 9, below 8, it has to come with a film. Okay, like for example, when you do full blood count and platelets is low, it has to go for film. You have to do a blood film because there may be clumps. So you shouldn't be happy reporting low platelets when other parameters are normal. You have to what? Check for clots in the blood, physical clot. You check the cover of the test tube. Sometimes they stick up there. There's no clot. You check the blood itself, the whole blood in the tube for clot. You don't see clot. The next thing is make a film and see if the platelets have clumped before you release the results. You see, so depending on the picture of the red blood in the full blood count, film may be indicated, and individual laboratories have to set those parameters at which point they have to do blood film. Okay?
Canada,
Yes.
one of the listed investigations was urine hemosiderin. What is the science behind that, and what would be the outcome if there is a hemolytic anemia?
Well, when there is increased the intravascular hemolysis, for example, then the iron loss will be found in there, okay? I'm just getting. For example, when you look at hemoglobin catabolism, we say that the hemoglobin, the red cell catabolism or red cell breakdown and hemoglobin catabolism, the heme breaks away from the globulin, right? and then the globulin is metabolized and release the amino acids that were used to build the protein back into circulation to be used again. Then the ion breaks off from the parallel ring, and then the parallel ring is processed into the bilirubin. Then the ion is also recirculated. But sometimes these deposits are found in the urine. And so it is an indication of the breakdown of red cells, where components of the hemoglobin are seen in the urine. If you get the rest being picked up by macrophages, like I was explaining earlier for the spleen, then the hemosiderosis happens in the macrophages. So there's ion deposit in the macrophages. When you do ion staining, you will see them if you were to get the tissues to do the ion staining. But in cases where they are not picked up within the system, then they can be found excreted in the urine. And that is where, because of the excessive release of or breakdown, you see the hemosiderin in the urine. Okay, and that is an indication of hemolysis. Yeah.
Yes, Doc. Understand.
Okay. Yeah. You have to understand that they are not particular tests. I mean, we have to have different way of arriving at a conclusion. And so you may not necessarily have to do all these tests just to diagnose one condition. Plus the fact that normally you are not even the one who decides the test anyway. But for example, you are in the lab and you are getting a funny picture. I have the desire and stop short in saying a habit of making sure that any results that a sign of I understand what it means. So even for your own curiosity, they didn't ask for these parameters, but you want to be sure that the ones they ask for, the results you have obtained are correct. You can do the other ones to support them. And if you came out for suggestions, you can also suggest the other tests. So they exist numerous tests to tell the same story, you know, and that has made life a little bit easier than others. Okay. All right. So can I go on now?
Yes, Doc.
Okay. So sickle cell disease, SCD, there's a beautiful sickle cell here. Okay. And that is the nicely shaped. Of course, it is a debilitating condition, so don't have to glorify the appearance of the cell, but you can compare to the normal red cell and then look at the appearance of them as compared to that one. You do know sickle cell is a genetic disorder. It's characterized by formation of a hard, sticky, sickle shape. See here, sickle shape red blood cell. In contrast to the biconcave shaped red blood cells found in normal individuals. Okay, and this disease is caused by mutation in the hemoglobin. What happens? So it manifests in early childhood, of course. For the first 6 months of life, infants are protected largely by elevated levels of hemoglobin F. Soon thereafter, the condition becomes evident. See, so when the hemoglobins are supposed to convert to the A after the fetal stage, that is when the problem begins to show. But at the stage where hemoglobin F, due to the type of globulin chain that is available, we don't have much of a problem. But when we get to the stage in life where the hemoglobin F will have been changed to hemoglobin A, then now it changes to S, and the condition will become evident. So pathophysiology, the hemoglobin S is from mutation due to substitution of thymine for adenine in the cis codon of the beta chain gene. So GAG now becomes GTG, and for just this change, over 340 million nucleotides. Just one change causes this condition. So there's coding for valine instead of glutamate in that position 6 of the beta chain. And for that matter, the beta chain becomes abnormal and forms the fluid typtoid, the crystallized hemoglobin under low oxygen tension, leading to the sickle cell formation. The resulting hemoglobin therefore has physical properties of undergoing marked decrease in solubility, and there's increased viscosity. So they become more viscous, they form polymers, and that's under the oxygenation conditions. Okay, they become polymerized. They form polymers, and also there's also exhibit changes in molecular stability. Then forms a gel-like substance containing hemoglobin crystal called tactoids. And these properties are responsible for the profound clinical expression of the sickling syndrome. So here you have a nice red cell like a donut, and then you have the sickle one like a fish. And this cell is hard, is not malleable, so it is difficult to go through tiny blood vesicles. This one, when it gets into the capillary, can become long and passes through the capillaries into the normal vessel. But the sickled ones are not malleable. They are just like if you put a sachet water on one side and you put a frozen sachet water on another side, or a sachet water that is about to freeze. You can, manipulate the one that has not received any freezing, but you can manipulate the frozen one. And so the vessels will be clogged with red blood cells.
Is it possible to see the previous slide before this one?
You want me to go back? This one? Or the
No,
previous?
please.
That
Yes,
one?
please.
Here?
The previous one. Yeah, this one.
Uh-huh.
Okay, I'm looking at the result age has the physical properties of undergoing decrease. Okay, okay, Prof. It's okay.
All right.
I'm okay. Thanks.
Okay.
Prof,
Yeah.
please, is it because of the sickle cell this thing, the hardness of it and the stiffness, is it because of that they normally have crisis?
That is what leads to the crisis. The crisis is lack of delivery of oxygen to the tissues. So there's tissue hypoxia, and that is what is said to be a crisis. So when they undergo, their cells become more sickled, they now begin to block the vesicles, blood vessels. So they don't, there's no release of transportation of oxygen to tissues becomes a problem. So it is like when you have run or cycled. Have you cycled to the point where your thighs are burning? We say that you have produced lactic acid, and it's as if the muscle is burning, like there's a heat burning inside. Have you had that before? Or run, go on a run, and your lungs are burning, and your muscles are crying for oxygen. Have you seen that?
Yes, please, Doc.
Yes, so that is it. What happens? What happens in that case is that because you are running and using your muscles and all that, and you are not getting enough oxygen through your tissue, the tissues begin to undergo hypoxic condition, that is less oxygen delivery to them, and so therefore they begin to give you that response. This is what sickle cell people go through. So when the cells sickle, like we see here, as I was trying to say, if they are traveling through the blood vessels and the vessel is tiny, they can't go. You know, this one here can turn itself, and it can be long, you know, long like a, you know, the French people's bread, that long one. So this round thing here can turn into that, what do they call it? The Polish bread.
Baguette,
You have seen it. Okay, you have seen that. So this is round like a donut. At some point, it can become like that because it's malleable, and then pass through tiny blood vessels, okay, and get to the other side. But this cannot be manipulated anymore. It's formed a shape. It formed a shape, and the typical one you will see is when you go home, put a sachet water in the freezer, and don't let it freeze completely. Halfway in the freezing, pick it up and see. You'll see that the water has formed crystals. And because they have formed crystals, if you are not careful, it can even cut you. You know, they will pierce the sachet. The normal one you see is if you were to put them in those rubbers they used to tie bengu. That's a soft one. Put the water in it, tie it up, and put it in the freezer for a while. Just before the whole thing freezes, go and take it out. You will see that the crystals will pierce the rubber, and the whatever water is in will begin to seep out. So, and then if you do another one that you haven't frozen, you can manipulate it. So this racer here can be manipulated, this one cannot. Meaning that in their travel through the blood vessel, and you know that in between the arteries and the veins, there are capillaries. And so the cell must move from the vein, pass through the capillary, release their oxygen, and get to the arteries and go back, or the vice versa. So when they get into the area of the capillaries where the vessels are tiny, they don't move anymore. So the tissues beyond that don't get the oxygen that they need. So lack of this oxygen transfer, oxygen transfer to tissues is what brings about the crisis that they go through. Crises are just the symptoms they get for lack of proper movement of their blood around the body. Okay? And so the sickling, the symptoms of the arrest are being sickled and unable to deliver oxygen to their tissues is what results, is what we will call that they are in crisis. You realize that during those times, if they are intubated and given external oxygen, then they are revived. But if you don't get that, then if you are not careful, it's going to go into somewhere else where they can even get become unconscious because oxygen is not being delivered to the brain and all that. All right, Timothy?
Yes, please. I'm okay.
Okay.
Thank you.
All right, sure. So here, as you see, hemoglobin S carries oxygen and begins to form semi-solid aggregate structures. And once oxygen is unloaded to the tissue, they begin to form that. These hemoglobin S aggregates distort RBCs and cause them to lose their normal elasticity. So even down here, you can see the rest are becoming elastic, and when the sickle ones block the vessel, there's what is called vaso-occlusion. So they block the blood vessel, vaso-occlusion occur, and if the cells were traveling from right to left and they are blocked here, tissues over here will not get any oxygen at all, or very little. So here you see 4 normal red cells and 3 abnormal, but there will have been 7 cells going through. Now only the 1 or 2 will pass through, and there is a blockage, and that is where the problem begins. So you can see also the normal reds going through a change and then being sickled. It is believed that when they are sickled is because they don't have oxygen, but once you give oxygen quickly, they are likely to, they can unsickle, okay? However, the danger side of this is that as they sickle and unsickle, it causes more damage to the cell and it will cause the cells to break down earlier than expected. It says hemoglobin S initially retains this ability to return to, that is what I was saying, to return to its soluble form, and then RBC can regain their elasticity upon reoxygenation. This process, however, harms RBCs, and with repeated deoxygenation cycles, permanent RBC damage may result. Okay? The abnormal interaction of sickle RBCs with vascular endothelium is considered a key contributor to the initiation of vaso-occlusion in the disease, and it's vaso-occlusion that leads to crisis. So how is the interaction coming about? There is a molecule that known as very late antigen 4 that sickle cells express on their surface. And these very late antigen 4 also interacts with endothelial cell molecule known as vascular cell adhesive molecule 1, VCAM1. So VCAM1 and VLA4 interact, and that allow the red cell that have sickle to attach to the endothelium and stop moving. So it's not only the shape that causes them to block, but when they become sickle, they express VLA4 that causes them to be linked to VCAM1, and then they stay. So VCAM1 is said to be also upregulated in hypoxia and inhibit nitric oxide. Hypoxia also decreases nitric oxide production, thereby adding to the adhesion of sickle cell to the vascular endothelium. And it is this adhesion that stops them from moving, all right? So yes, the shape also plays a role, that is compounded by the fact that they produce a stickiness on the surface that allow them to stick to the endothelium and stop movement. Okay. And this lack of movement is what leads to the vaso-occlusion. All right. So the methods available, there's one that I'll talk about that is rarely done now, which is the solubility test. Hardly done, but you need to know as well. So there are three categories of the test. Independent, which is dependent on the abnormal physical properties of hemoglobin S. So firstly, the sickling test depends on the distortion of the red cells membrane associated with the linear polymerization of the hemoglobin S molecules during deoxygenation. Secondly, so this is the sodium metabisulfite test. The second one is solubility test, and it's based on observation that deoxygenated hemoglobin S is relatively insoluble in phosphate buffer of high molar concentration, so they'll precipitate out. So when the cell has hemoglobin S and you put it into the phosphate buffer, there will be precipitation, and therefore you don't see through the test tube. And I'll show you a picture. So then the third one is almighty hemoglobin electrophoresis that reflects the net positive charge resulting from replacement of glutamic acid by valine in the hemoglobin S molecule. So sodium metabisulfite is added to the blood, and this one is like is it like brushing your teeth? Everybody does it. If you work in any lab at all, you never did sodium metabisulfite sickling test, and something is up somewhere. So when you put the bloods on the slide, add sodium metabisulfite, that will create and cover slip it. Once you apply the cover slip, a hypoxia condition will be created, and the cells will begin to cycle over time. And begin to cycle over time, and when you examine under the microscope, you see them fine cells cycled over here. Okay, this is the solubility test. So is used as a screening method for sickle cell anemia, relies on the relative insolubility of hemoglobin S in concentrated phosphate buffers compared to hemoglobin A, another hemoglobin variant. Hemoglobin S precipitates using a cloudy or causing a cloudy solution. So you draw, there's a paper and you draw a line on them, and you put that paper behind a rack, and then you do the test and put them before the lines on the paper. And if you can see through the test to see the lines, like on the left here, then the sickling negative. If you cannot see the lines like on the right here because of precipitation, then that test is sickling positive. That is the solubility test. And then electrophoresis agarose gel, or what they call cellulose acetate paper, as well as agarose gel. You will run a control. So the control here is AFSC. So A is here, F is there, S is here, and that is C. And when the test matches any of the controls, then you can conclude. So here we are seeing all the bands in one side matching S, and that is homozygous S or SS. And then when the gel, for example, is wide, you run the control on the side and then in the middle. O2, May Queen, Yasmin. Yasmin, you raise your hand.
Hello, sir.
Yes.
Yes, may I see the slide for the solubility test again, please?
Okay, here you go.
Thank you.
You satisfied?
Yes, sir.
You got what you
saved it.
want.
Thank you.
Okay. All right. So this is run here, and we have a band matching A, another band matching S, and that is hemoglobin A and S for this individual. This is hemoglobin S and C, hemoglobin A and S. That is a neonate, AF. This person is likely to be A. This is a normal adult, AA. Don't forget that we inherit this in pairs. So we are always going to express double of them. So when you have them on one spot, it means that two are the same. The two inherited by you are the same. So that's why you have the AA and then the SS. Okay, so that is the electrophoresis testing. Once again, I'm not going through Mohammed.
Yes. From the slide from the number 2, which you said is a normal adult, for the agarose gel electrophoresis. I don't know, it will be accurate for us to actually report it as AA or report it as a single band at A, because it's just a single band.
That's why I'm saying that we know everybody has 2 types of hemoglobin. Okay, so you can't have a single A. Every individual has 2. So when they are all on the same band, then we assume that you have the same, your 2 is the same, if that what I'm saying is correct. So everybody is supposed to have 2 types of hemoglobin, not 1. So you can't say the person is hemoglobin A when you have done electrophoresis. All right, so it's AA. Of course, we say that hemoglobin A, but the person is AA, isn't it? So everybody is supposed to have 2 of them. So therefore, when all your hemoglobin is on the same band, then it means that the 2 that you have are the same. Like here, we have SS. So when you have all your bands are here, it means that the 2 you are supposed to have are all the same. So they will be on the same band. They run the same way. You get it? So if you have all your hemoglobin bundled at the same place, then the assumption is that they are both A, because you should have 2, not 1. Is that correct for you?
Yes, please. Thank you.
Okay. Yeah. All right. So that is how you interpret
Prof.
it. Yeah.
Yeah, please. Will I be correct, or is it appropriate to say in a case for neonates where they have hemoglobin F? From this diagram, realize that the 3 is a normal neonate F.
Yeah.
So is it also appropriate to say that it's also having hemoglobin FF?
If they were all here, if it's only 1 band, but there's 1 there. Okay, so if all the bands were here, if there wasn't this one, then that is FF, because they are supposed to be 2. Per this interpretation. But in this case, there is 1 here and there's 1 there. There are 2 bands. So you have to name this and you have to name that. And that is A and F. Yeah? Okay. And we expect that eventually this one will disappear and it will all be A. That's why it is a normal unit. Okay.
Okay. My second question has to do with I know that when you do HB electrophoresis, you can report if it's A as AA. And we know that we have hemoglobin A1 and A2.
Yes.
So in that case, when you run the HB electrophoresis, and is A, and realize that the band is not like it, I see a little bit the control band of A. Which test can we do to ascertain that maybe this is hemoglobin A1 or A2?
You have to do molecular tests. Yeah,
Okay.
because just because they are passing a little bit, you can't say that it's different from that one. Because the dropping of the blood is humanly done. So you cannot put them exactly the same place. Plus the fact that the content, the quantity may differ on those things. So the electrophoresis will just give you this one. But there's another stage that you can go to determine. So in some way, you could say this is qualitative to some extent, but to be very sure of the molecules that the person, to be very sure if it's A2 or that one, you have to go beyond. And even HPLC can give it to you as well,
Okay.
Richard.
Hello, Doc.
Yes.
Please, why is it that when we do the sodium meter by sulfite test for hemoglobin C, it doesn't sickle? So
What do you want it to sickle?
But when you do the listing, it shows C, maybe AC, you don't see any sickling, but
yeah,
when you do
because C doesn't sickle.
Okay.
The mutation for C is different from S. So the C doesn't sickle. The only electrophoresis can tell you. So AC people shows up as sickling negative, which is a fact. So when you do sickling negative, you cannot call it A. You get it? Because AC is also sickling negative. So C don't sickle. That is why normally, most ACs are normal people. However, when you get C and S combination, that becomes another story. So a person with AC, they try to avoid AS people or SC people because without the A, there's always going to be some problem. Yeah?
Yes, sir.
Okay. All right. So we have 10 minutes to go. Let me see what's next. Okay. So that's the summary. Fact to note, hemolytic anemia involves the following: abnormal and accelerated destruction of red cells, and in some cases, they are precursors. Increased breakdown of hemoglobin occurs. Bone marrow compensatory reaction occurs. So we see reticulocyte, okay? And the balance between red cell destruction and marrow compensation determines the severity of the anemia. What are we saying here? If there is a wide range between destruction and compensation, anemia is severe. But if the range between destruction and compensation is very close, it means that 10 is destroyed, 7 is produced. Anemia is marked. But if 10 is destroyed and 2 are produced, then anemia will be severe. Okay, and that should be the end for today. Unless you have more questions, you have 6 minutes to.
Yeah, Prof.
Yes.
Yeah, I was just thinking through the hemoglobin S.
Yeah.
From the start, you were saying that for the neonate, from the neonate, after 6 months before the mutation starts.
Yeah.
Yes, and
not before the mutation.
hemoglobin
No, the hemoglobin. Have you determined the lines for alpha and beta hemoglobin? The delta and epsilon and those things. Okay. So hemoglobin F is what?
Alpha
Beta
2
and
delta
what?
2.
Huh?
Delta.
Delta and
Delta.
beta. Okay, I stand for correct.
Alpha and
So let's say
alpha
delta.
then.
Alpha is what?
For ADF, we have alpha 2 delta.
It's alpha and what? Delta, right?
Yes, delta, yeah.
Delta, yes.
So when the delta changes to beta,
Alpha and gamma.
okay, alpha and gamma. Okay, so there's always alpha and one other. So let's say when the gamma changes to beta, in that line, there are two lines. The alpha, I think, is just epsilon and alpha or something like that. I haven't cross-checked. So there's always going to be alpha and one other, but the other one changes. So if we say, what did you say this again? Delta? Did you say the F is alpha and delta?
The gamma. Alpha.
Gamma.
Alpha 2, alpha 2 gamma.
Okay. So the gamma will eventually change to beta, but it takes a while, a little while. So when the gamma changes to beta, then the hemoglobin then becomes A. But when the gamma is existing, then it's a hemoglobin F. Okay. So for young ones who are likely to become A, the F will be on for a while, whilst the gamma remains. But as gamma changes to beta, the F disappears and the person is A. But the S will also come in if there's a change in the beta chain. Don't forget that gamma chain is in line with beta. So eventually, instead of the F changing to beta, it will change to beta, all right, but the beta will be damaged or is mutated beta. And obviously the mutation, I have to check whether the mutation is seen in the gamma. I'm not sure. But if it's not seen in the gamma, then it means that once the sickle cell person's gamma changes to beta, the sickle will be expressed. Okay? But most often, the hemoglobin F is in line to become beta, which is making their hemoglobin to be A. But if that beta has a mutation, then once the gamma converts to beta, the mutation will stand out, and the hemoglobin cell becoming A will be S. Okay.
Okay. Thank you.
And if they have another A somewhere, then it is A. Yeah, that is one. Okay.
Okay.
Sure.
I don't know if I can still ask my question since the time is almost up. I was looking at the question that Richard actually asked with respect to the hemoglobin C sickling when you add the bisulfite.
Sodium metabolism.
So in that case, I was looking at how does the sickle cell hemoglobin C actually cause the sickling or the occlusion, where they can also have cases of crisis. In that regard, since they don't actually sickle.
Yeah, but hemoglobin C program, when we see it in sickle, is SC, or when it is CC. The double C, I can't get to the pathophysiology now, but when the person has double C, they may have some sort of crisis. When they have SC, they may have some sort of crisis because the C's are not like the A. But under sodium metabisulfite, the C will not sickle. That is what is known. So when you do sodium metabisulfite test, even CC, you are likely to get it negative. Only that is how come I said that you cannot rely on sodium metabisulfite to say that somebody has not got sickle cell disease or even a trait. You need to go beyond that. So if it is negative, it can be AC and not AA. Some people, when they do sodium metabosulfite as negative, they write that the person's hemoglobin genotype is AA. That is wrong. You can only do the genotyping when you have actually done gene expression, which is looking at the electrophoresis or column chromatography or doing a molecular testing for that matter. But if you didn't do that, then the sodium metabosulfite is a qualitative test, and C doesn't cycle under sodium metabosulfite. There is some amount of mutation in there, but it is not, it doesn't form the tactoise as the S does. Okay. And that is where the difference is. Okay.
No, so please,
Yeah.
the substitution is not the same as the S. The substitution.
No, it's not at the. I was trying to get it for you, where the problem is with C. It is not the same place, but it's still with the beta chain though. Okay, let me see if okay, in my next lecture, I'll give you what the exact point of the mutation in the C. That's not the same. Yeah. So of course, it's a hemoglobinopathy. However, the severity of the problem is not the same as so what you can say is that even though the C is less soluble than A, all right, but it is not, it's also more soluble than S. Okay. So okay, this is the algorithm. In the case of the hemoglobin C, the glutamate is replaced by lysine. Okay, it's replaced by lysine. And in the S, glutamate is replaced by what? Valine. All right? Correct?
Yes.
So the change is different. And so therefore, the solubility aspect is also varied. There's variation in the solubility of the hemoglobin. Okay, so when we looked at the test here, I said that what is it? There's the S precipitate, so it is very less soluble. Okay, so if you want to range the solubility, then A is more soluble, C is relatively soluble, S is less soluble, something like that. And because the changes are different for each one of them. And that is how come the C is closer to A and doesn't cycle under sodium metabosulfite. And even then, when you do sodium metabosulfite and the person is SS, almost all the cells will cycle, isn't it? But when the person is AS, not all of them cycles. You know, I mean, that is also a fact that exists. So under sodium metabosulfite, hemoglobin C will not cycle. Therefore, you cannot take cycling negative as AA, because there's a chance that the person can be AC or even CC. All right. Right. Okay, so we are past our bedtime. and we stop here. Let me see if I can pick quickly my next meeting with you guys. Where is this one? Okay, keep this one here. Right, so today is the, we did yesterday 13th. The next one will have been the 21st. Okay, so I guess I stepped in for someone to cover one of the ones we missed. So the next meeting is next week, the 21st. Okay. All right. Until then, have a good evening and a good time. And I will see you when we next meet. All right.
Thank you, Prof.